in dying. Hello, I'm David Oliver. Very pleased to see you all. We've got a session, interesting session on medical aid in dying. And we've got three very good speakers to listen to for the next few minutes, and then we'll have a session with questions and answers at the end. Look forward to seeing you later.
Good afternoon. My name is Tim Quill, and I'm here to present about palliative care, hospice, and last resort options in the United States. I am a palliative care physician, have been so for many years at the University of Rochester. I have no significant conflicts of interest to disclose. I am an advocate for better palliative care and hospice and for the possibility of a physician-assisted death as a last resort. These are some photographs by Imogene Cunningham about people alive and functioning into their 90s. And when we use medicine's powers to keep people alive and functioning into their 90s, we are doing a wonderful thing. Palliative care tries to do that. We are trying to hope for the best as people get sicker. We're going to search for medical options, explore even improbable or experimental therapy, although we'll always listen carefully to what the risks and benefits are and make sure people are fully informed if they take that kind of path. We also attend to the present, so whatever symptoms a person is having at a given point in time, we will carefully manage. We will attend to depression and other psychosocial issues, maximize quality of life. And if the patient is willing to go there, we will also prepare for the worst potentially. So make sure, in case things don't go as we all hope, that affairs are settled, that there might be unfinished business that should be worked on, and be open to the exploration of spiritual and existential issues if patients and families want to do that. So this is the sort of graphic model of palliative care. It is often provided alongside life-prolonging therapy, although as people get sicker, the amount of life-prolonging therapy goes down, palliative care goes up. And then in the United States, at least, if you are going to purely palliative care, so you accept that the end of life is really approaching, you might go on to the Medicare hospice benefit. This is a picture of Elizabeth Kubler-Ross, who is the mother of the hospice movement, probably in the United States. Dame Cicely Saunders would be on this slide if this was being given in England and perhaps other parts of the world. There might be other people who really began to awaken people about all the possibilities that can occur toward the end of life. But there are some challenges to the discussion about hospice. It is not a good day for patients when they're going to be going toward hospice. It definitely requires a bad news discussion because people have to accept that treatment isn't working, that they're more likely than not to die in the next 6 months. There's no requirement to die in 6 months, but they're still more likely than not. And they have to give up on hospitalization and disease-driven treatment. Many people may be willing to accept some of these limitations, but they don't want to stop all treatment, and they may want to try some even improbable burdensome treatment. And again, if they go into hospice, that's not possible because, and the reason why people choose these options is because small chances of cure or longer life are at the core of hope for many people. On the other hand, most patients are very satisfied, as are their families, when they transition to hospice in retrospect. So sometimes people ask one of the tougher questions, what happens if my suffering becomes unacceptable to me in the future? This question might be relevant early on as people are thinking about the future, as they're wondering what things might look like. And it might be an immediate question later on in the course of a person's illness. So again, reassurance about the future. If you can tell people, you know, we do have means for addressing a lot of these challenges, that we will be with you during this process. We'll try to help decide what people are worried about, hear about their fears about death, about suffering, and also commit to facing the worst case scenario if that's where things go. People who know they have a medical partner who's skilled in palliative care and knowledgeable about end-of-life care really can go forward with their treatment and with their illness without being as afraid, because they know their clinicians will come through for them if they end up in a tough situation. But if we do make this commitment, and a patient really says they're ready to die now, we must be there and be ready to work with them to try to find an answer. And again, the first place way to go with this is to explore the why now, what makes suffering so unacceptable right now. And there's a differential diagnosis to this process. It might be uncontrolled symptoms, pain, or shortness of breath. They might be becoming confused from delirium. They might have developed a psychosocial problem. Perhaps their family is getting tired caring for them, or they don't have enough support to be able to stay in their own home. They might have a spiritual or religious crisis. How could a caring God or caring being have allowed this to happen to them? And they may also have become clinically depressed or clinically anxious, in which case the proper place to go first would be to try to address and treat their anxiety and depression with a combination of medicine and conversation. But it also may be that they have begun to experience uncontrolled, unacceptable suffering, in which case we have to come to grips with what options they might be interested in. And here's a list of the what I call last resort options to respond to intractable suffering in rough order of societal consensus about acceptability. So the ones in green generally agreed upon as being acceptable. So if a person is in pain or short of breath, we can proportionally increase the dose of opioids or sedatives if they are needed, even to the point of rendering them unconscious if we can't relieve it with lesser degrees of intensity of treatment. We can also not start life-sustaining therapy, or if it has been started, it can be stopped even if a person is desiring to die more quickly. Some of these life-sustaining therapies are big ones like ventilators or dialysis machines, but it also may be small life-sustaining therapies like antibiotics or fluids. And again, these are all open to being tried, but also being stopped if a person has decided they're ready to die now. In the orange area in the middle are two of the gray area, I would say, from an ethical point of view. One is proportionate palliative sedation that might go all the way to unconsciousness. You're trying to use the least amount that will relieve the symptoms, but we can go to very heavy levels if we need to. And that is widely agreed upon as an option in the United States and probably Western Europe as well. Even a little bit more controversial is the option of stopping eating and drinking. This is people who are physically still capable of eating and drinking who are stopping eating and drinking to die more quickly. And again, this seems to be a permitted option. There's no legal prohibition for doing it, although it is a challenging undertaking, so people have to be really committed to taking it on. Then in the bottom area are the more controversial options: physician-assisted death, also called physician-assisted suicide, where the clinician or physician may make potentially death-hastening medication available to the patient that he or she must take by his or her own hand. So the physician is an assistant in this, but the patient is the final actor. Voluntary active euthanasia is similar to this, but in this case, the clinician is the final actor in that they deliver the potentially lethal medication at the patient's request. So there's a voluntary consent, but it is clinician delivered. Physician-assisted death is legal in 10 states and the District of Columbia in the United States. Here are the list of states. Some of this has been done by referendum where the public have voted on this question. Oregon, Washington State, and Colorado. There's also been legislation in several other states. And in Montana, there was a court ruling. There's a lot of other legislative activity underway in 20 states, although these decisions and processes are quite labor intensive, and they're very controversial when they're going through. Some of the data from Oregon, which in the United States has some of the longest experience with a physician-assisted death. These are some old data, but they're probably some of the better studies that we have. that 1 in 6 terminally ill patients talk to their families about this option, 1 in 50 talk to their doctor about it, and it accounts for only 1 in 300 deaths when it is legal. So most people want to talk about these options, but relatively few ultimately act, at least by this means. So the other last resort options may be much more commonly used, at least in the United States. So there is a need for safeguards for all of these options of last resorts to protect vulnerable patients from error, abuse, and coercion, to ensure access and adequacy of palliative care, which is the standard of care for people who are sick. The risks cited for physician-assisted death are also present for other last resort options. So any kind of safeguards that we build in must balance flexibility and accountability, and also must balance privacy, protecting the patient and family confidentiality, and oversight so that we can make sure the processes are working properly. The categories of safeguards, again, these vary a little bit jurisdiction to jurisdiction, but these categories are generally the common ones. That palliative care has to be accessible and found to be insufficient. You don't have to try everything palliative, but you have to be aware that it exists and not suffer from things that could have been relieved that you don't know about. There needs to be rigorous informed consent, so you really know what's you're consenting to. Diagnostic and prognostic clarity as much as possible in terms of the underlying disease and where it is going with and without treatment. An independent second opinion, ideally from somebody who has experience in the disease process that the patient has, but also potentially somebody with expertise in palliative care. And then documentation and review so we can make sure these processes are being done properly. So palliative options of last resort, the bottom line, they are only sensible in the context of excellent palliative care. So the first place, again, if people are suffering, is to make sure they're getting adequate care. Currently, options are very unevenly and unpredictably available in the United States, especially the legal landmarks for particularly a physician-assisted death and euthanasia are pretty uneven and largely prohibited. And the other options, such as sedation, there's a lot of variation in how quickly doctors go to these options. Same thing with stopping eating and drinking. In my opinion, all of these options should be subject to similar safeguards, and that open processes, the real argument for putting this out in the open is that they're ultimately safer, more predictable, and accountable for patients and families. So clarity about which options and circumstances would be beneficial. It reassures those who fear a bad death. It increases responsiveness to extremes of suffering. There's more ability to address unique circumstances and more accountability when suffering persists.
Hello all, I'm Ludo Vanopdenbosch. I'm a neurologist and palliative care physician in Bruges, Belgium, and I would like to thank the organizers for inviting me to share my experience with euthanasia in neurological patients. To give you an idea of what we are talking about, I will tell you about a patient I'm at present attending. Mark is a 66-year-old retired school teacher, and he was diagnosed with lung cancer a couple of years ago. With local treatment and ongoing immunotherapy, he has stable lung disease. I saw him a first time a couple of months ago after a first epileptic seizure. Brain MRI showed several brain metastases. I started him on anti-epileptic drugs and referred him for radiotherapy. At that time, he already told me that he considers euthanasia in case his disease might become hopeless. A couple of weeks ago, he was admitted to the emergency room with subacute left-sided hemiparesis. Brain imaging showed progressive brain metastasis. Continued home care seemed to be difficult because his wife is still working, and he was admitted to our hospice and steroids were started. However, his condition only worsened, and now he's bedridden, totally dependent on nursing care with a left-sided hemiplegia. Since about 2 weeks, he expresses a wish to die and asks for euthanasia. His wife and adult children at first did not want to have this discussed, telling him, "We do not want to lose you, and we will do our best to be here as much as possible." I have had several talks with Mark and his family, and he tells me and his family that he does not see any meaning in the suffering that my Leha had for him in the next days or weeks leading to his death, and that he wants to die with dignity through euthanasia. He has written this down as well. An independent palliative care physician has seen him and has confirmed that his disease is hopeless and his wish for euthanasia is genuine and free of external pressure. We have set a time and a date for euthanasia next Monday. On Monday, I will first go to the hospital pharmacy and collect pre-filled syringes. I then will go to the room of Mark where his family will be gathered. I will sit down and tell Mark, "You know why I've come here. I have medication with me, on administration of which you will die. Is that what you want?" As always, he will say, "Yes, doctor, very much so. I've been waiting for you. And thank you for helping me and respecting my wish." I will then ask, "Is there anything you still want to tell your family?" And invariably he will say, "No, everything is set." I will then administer intravenously midazolam in fractionated doses till deep sleep, followed by 3 grams of pentobarbital, and Mark will die instantaneously. I will sit a few minutes next to him in silence. I will stand up, tell the family that Mark has died. I will condole them. I will leave the room, and I will take a few moments for myself and have coffee. I then have to fill out a form which detailing the procedure which I sent to a governmental committee overseeing euthanasia in Belgium. What I just told you is perfectly legal in Belgium. However, it certainly is not in most parts of the world. Even in France, less than 100 kilometers away from here, this situation will definitely lead to criminal prosecution. In 2002, the Belgian king signed a law passed through parliament decriminalizing the existing practice of euthanasia. Without wanting to go into the legal technicalities, euthanasia is possible in 3 different situations. First, the patient has a disease which will kill him within foreseeable time, with oncology and diseases like ALS overrepresented. Secondly, the patient has a disease which is life-limiting and life-threatening, but will not kill him within foreseeable time, with neurological diseases such as multiple sclerosis and Parkinson plus syndromes overrepresented. Third, psychiatric patients with intractable suffering. Since the motivation to pass the law was essentially the absolute autonomy of the individual to decide what happens to his own body, including death, this last category of psychiatric patient is the most controversial because psychiatric disease is not complete autonomy of the patient, but has a relational aspect as well. We do not have the possibility for euthanasia by advanced care directive in end-stage dementia. We have this for coma, but euthanasia in coma is very rarely performed. My personal thoughts. First of all, I do not feel I am killing a patient. The disease is killing the patient. The brain metastases are killing Mark. What I am doing is using my medical skills to assist in the dying process, respecting the wish of the patient. Nurses and family members having seen euthanasia often express that when their time will come, they also will want to die through euthanasia, because euthanasia, medically assisted dying, is good death. In requests by patients for hastened death, I feel the law allowing euthanasia has shifted the focus towards the patient. When a patient asks me, "Doctor, please help me to die," earlier before the law, I would have answered, "I am not allowed to do this. I will be prosecuted." Now with the law, I sit down and I answer, "Please tell me, what do you want? Tell me, what is your unlivable suffering? How may I help?" Perfect palliative care does not take away requests for euthanasia. Most patients are well controlled with parenteral morphine for pain, antiemetics for nausea, and so on. However, they do not see meaning to go through the end stage of their disease. A good example of this is Parkinson plus syndromes, with cognitively intact patients trapped into unwilling and frozen bodies who express that this is no living anymore and they want to die. Euthanasia and suicide are very different things. In suicide, the patient only thinks about himself. He doesn't see a way out. He has a very narrowed focus of attention and is very impulsive. And this usually lasts less than 24 hours. In euthanasia, patients are very concerned about their relatives left behind, are worried about the doctor getting into trouble. They have been thinking slowly about euthanasia night after night. If the motive for euthanasia, for a request for euthanasia, is lack of care, if the patient says, "I do not know who will take care of me or where I have to go to," we will not do euthanasia. We will try to organize proper care. Also, families will react, saying, "We do not want to lose you, and we will do our utter best to take care of you or to find a solution." Despite having legalized euthanasia for almost 20 years, we have not seen the feared-for snowball effect with a tsunami of euthanasia requests from the very elderly, tired of living and waiting for death in elderly care facilities. We have seen a tsunami of deaths and a shocking social isolation in this population with the recent COVID crisis. 85% of the population where I work in is in strong favor of euthanasia and are very critical of any attempt to scale back the law. I have to stress that this population is not culturally diverse. About 80% identify themselves as Christian, but only 1 to 2% are active churchgoers. I'm aware that feelings towards euthanasia are very different in other parts of the world. And finally, when talking about the possibility of euthanasia with patients with neurological disease and answering their questions about euthanasia, I have often noticed that it gives them courage to go on. They know there is a way out when their disease might become unlivable, as some sort of an emergency exit. It gives them hope and strength to continue living with their disease. Multiple sclerosis specialists and myself have a strong impression that this has prevented suicide in our patients. However, scientific research has not proven this yet. I thank you.
Thank you for asking me to talk about the law around so-called medical aid in dying and the proposals. I'm Ilora Finlay, and I am in the House of Lords, where we've just had a debate recently. Interestingly, a lot of the reasons that people were giving around wanting a change in the law related to bad care, deficits in care. They were relating problems in care provision, and a lot of the reasons that were given against the legislation relate to the complexity of and inadequacy of safeguards and the unintended consequences of changing the law. So I'm going to try to deal with those. What are we talking about when we talk about assisted dying? We're talking about either physician-assisted suicide, where the person themselves ingests orally the lethal drug. Used to be phenobarbital used most of the time, but in the US, its availability has dropped because it had been used in judicial executions, and also the price had gone up hugely. And therefore, drug mixtures are being used, combining cardiac-type drugs in overdose, I think to induce a cardiac arrhythmia and cardiac arrest as a mode of death, but with some sedation as well. In euthanasia, the lethal drugs are injected into a vein, short-acting anesthetic agent, and sometimes, but not always, followed up by curare as an agent to paralyze the person completely so they can't move a muscle, they die of asphyxia. There is a concern that some patients might have regained consciousness before they die of the asphyxia, particularly if there's a major anoxic drive as they're dying of asphyxia, but I haven't seen any studies monitoring brain activity during death from euthanasia. I've written a book. My colleague and I tried to look at the balances of the different arguments for and against around personal choice, control, the effect on palliative care, and that word dignity. Dignity was defined by Cicely Saunders as having a sense of personal worth. And it's often said that people have lost their dignity when they've become ill, but actually the way that people behave towards them either takes their dignity away from them because they feel that they have less personal worth, or it can be used to enhance their dignity. Harvey Chochnov has shown that quite clearly. If the law has to change, if you decide the law has to change, then you have to decide, how does it change? Do you assist suicide? Is it the physician involved in doing that, or is it physician-administered euthanasia? And what happens when the law changes? Are there unintended consequences? Looking at the Oregon reports, and they've reported every year since their law changed, so the latest report shows that the concerns at the end of life remain those in much more of the existential domain rather than because of pain or distress. Pain control or fear about future pain comes way down the list of concerns, but being a burden on family, friends or caregivers is a major end-of-life concern in around 53% of people, and at the top of the list comes being less able to engage in activities that make life enjoyable. The sad reality, of course, is that lots of things change as we progress through life. When we talk about pain, it's important to remember that concept of total pain that Cicely Saunders gave us and framed, which is that there is a physical stimulus for the pain that needs to be treated. You use morphine to kill the pain, but you don't use morphine to kill the patient. But that pain experience is enhanced by emotional, social, and other concerns. A person in turmoil, depressed, not sleeping, will feel their pain experience far more than the person who is kept comfortable, knows who they can rely on, knows that they are loved and valued. Is stopping treatment euthanasia? No, it isn't. You have to consent to be treated, and you can withdraw your consent at any time. In deciding whether to instigate or whether to cease a treatment, clinicians are always weighing up the risks and burdens against the benefits. Similarly, patients weigh up the risks and burdens against the benefits. And when the benefits are outweighed by the burdens or the risks, they can withdraw their consent to ongoing treatment. And when they stop treatment, that treatment must be withdrawn. They've withdrawn their consent. It would be assault to continue it. If we think about motor neurone disease, or ALS as it's called in many parts of the world, if a person has been, for example, ventilated at home, they have been kept alive far longer than they would have lived if they hadn't had that ventilation. When they say enough is enough, they don't want to carry on with the ventilation, they must have all care as they are dying. They die of the disease from which they would have died previously. This is not euthanasia, this is treatment refusal. And that is quite different. And whilst they're dying, they must be given symptom control and looked after so their death is gentle and peaceful, but they're not given lethal doses of drugs. They're kept comfortable with careful titration of drugs as they're dying. In euthanasia, you give a massive overdose of lethal drugs with the sole intention of ending life, and you're ending life months or years earlier than it would have otherwise ended if the person had gone on to die of their underlying condition. So in legislation, people talk about there being safeguards against abuse, safeguards to make sure that only the right people who fit within a certain set of criteria get lethal drugs. And in many bits of legislation, and this is certainly one in the UK that's been put before the Westminster Parliament, it is to enable adults who are terminally ill to be provided at their request with specified assistance to end their own life. So there are three main areas in this. First of all, that it must be voluntary. Secondly, they must have the mental capacity to make that decision. And thirdly, they must be ill. They must have a condition which allows them to fit these criteria. And in the bill before Parliament, terminal illness is defined in this way. Similar to the Oregon definition, it's a condition that can't be reversed by treatment. The person is expected to die within 6 months, and treatment which only relieves the symptoms is not to be regarded as a treatment that can reverse that condition. And this condition is meant to be inevitably progressive. Questions were asked of Oregon as to how they define this. And of course, most diseases become terminal if patients refuse to take whatever medicine is prescribed for them. Take insulin-dependent diabetes, type 1 diabetes. The person will die within probably 6 months if they have no insulin at all. That is a progressive condition. It will inevitably lead to death without treatment. So actually, anyone with type 1 diabetes could fit into this definition. There are many, many diseases that progress on. The 6-month prognosis is a problem, and I'll come on to that in a moment, but it is a guesstimate. What about being terminally ill, though? What about the underlying illness? Well, the select committee that I was on at the House of Lords that looked at this legislation previously heard from the Royal College of Pathologists that there is a 30% error in medically certified cause of death at post-mortem. And there's a misdiagnosis of terminal illness in around 1 in 20 cases. I'm afraid we make diagnostic errors. What about prognosis? Well, medicine is a probabilistic art, we were told. And as the College of GPs told us, when death is thought to be 6 to 8 months away, it's a pretty desperately hopeless as an accurate factor. The Liverpool Care Pathway, which fell into disrepute and was meant to only be used when someone was thought to be in their last 72 hours of life, found, looking at their data, that even when people were in the last 48 hours of life, 3% of people improve. We cannot predict prognosis accurately. I'm sure you can all think about the number of times you've been wrong, and you can probably count on the fingers of one hand the times that you've actually been right. So the problem is the information on which a patient might be even making a decision to ask for lethal drugs is very flaky indeed, because we get the diagnosis wrong and we can't predict prognosis. We're pretty hopeless at giving good information. What about mental capacity to make the decision? Well, it looks simple when it's written down in law. It sounds as if it's objective, but actually the amount of capacity you need depends on the decision at the time that you're taking the decision. And the problem is that in neurological disease, a lot of people are cognitively impaired. In motor neuron disease, it's around 30%, similarly in Parkinson's. In multiple sclerosis, of course, it's higher than that. And that cognitive impairment is worsened by depression and hopelessness, which are mutually reinforcing factors. Major depression is significantly accountable for impaired capacity, and medication and metabolic changes also can impair capacity. We are poor at assessing capacity, and this isn't a one-off assessment. This is a really complicated process to see whether somebody does or does not have capacity for the decision that they are taking. They may lack capacity in some areas, but not in others. And of course, they must be supported to make their own decisions as much as possible. And support means reversing all the reversible factors that you can. And what about voluntariness? This is the most difficult one. It's meant to be a safeguard that it is the person's voluntary wish, but we don't know what goes on behind closed doors. I'm sure many of you have been taken in by what you thought were loving families, but actually you discovered later on that they weren't. And coercion in families may not necessarily be malicious. The family may just be exhausted. They may have financial pressures. They may find care difficult, and the person is worried about being a burden. And that's a powerful influence on their thinking. And they feel that they ought to do the honourable thing and die. They have a duty to die, rather than that's actually what they want. And don't forget the power differential between the patient and the doctor. The doctor who is pessimistic towards the patient, who doesn't show a commitment to care, will give the message to that patient, I think you're better off dead. And that is a very powerful influence on patients and on their thinking. And as for a clear and settled intention, well, that's difficult because we know that the wish to live and the wish to die fluctuate, and that's over a variable amount of time. So we're very poor at knowing what goes on at home behind closed doors. We don't know coercive pressures that people are under. When you look at what happens to care provision when you do change the law, the numbers go up. It's worth noting that always initially they look as if they're not going up hugely, although Canada has bucked the trend with really dramatic increases in their numbers. Very rapidly, when you cut a hole in suicide prevention policies, you find that you get an escalation in those suicides. But it isn't only in assisted suicide and euthanasia that you get an escalation. You don't see a drop in non-assisted violent suicides in these jurisdictions. Their rates are high. It's as if something culturally changes within those societies. And it may be that clinicians are finding it more difficult to implement suicide prevention policies as well and approaches. But the numbers are really huge. If I translate that for England and Wales, the Oregon rate, which is assisted suicide only, would come out at about 3,200 deaths a year. But if I look at the Benelux countries that and translate that, where there is also euthanasia, those numbers come out at about 23,000 deaths a year for England and Wales. So these are big numbers. Nobody should think this is just a small number. And look how Canada's numbers have just shot up. You change the mode of care. Canada, where we can see the lived experience happening, there are concerns, particularly for people with disability. Roger Foley had tried to go to court to get the support he needed to live well, but he was denied those arrangements, but was told he was free to pursue a medically assisted death. And the vulnerable person standard reported they have little confidence in made decisions being appropriately grounded in effective communication, especially for patients who have disabilities that affect their communication. And the UNHCR, looking at disability rights, reported being extremely concerned about the implementation of the legislation on medical aid in dying, medical assistance in dying, from a disability perspective. People with disability needing support to live well are particularly disadvantaged in such legislation. These laws expand. Are there other unintended consequences? There does seem to be a dwindling of supportive care. Palliative care does not develop as fast in those countries that have changed the law. Initially, there's often some money put in to improve palliative care services, but that improvement is not maintained. Of course, palliative care is improving everywhere in the world. So I would hope that it has improved to a certain extent, also in those countries that have changed their law to go down this road, but the rate of improvement is less than in countries that didn't legislate in this way. The conscience clause does not seem to be working at all in Canada. Some hospices have lost all their funding because they refuse to provide euthanasia on their premises. And I've already spoken about, it's the failure of such legislation to cut down violent and non-assisted suicides. But also there seems to be moral injury to doctors. It's worth people reading about the experience, particularly of doctors in Belgium, who had previously supported such legislation, but say they've had enough. They don't see this as a medical duty. There are unintended consequences, and we cannot ignore them.
Thank you very much to all the speakers. It's given us a lot to think about. I'm looking that we do use the question and answer, though participants are watching. I can see there are over 40 of you, or the chat. I'll take the one question we have had. This is the system for MAID, I'm told, is similar in Netherlands and Belgium, except in one respect, that deaths are notified and the information is in the public domain in the Netherlands. Is this still correct? And how does this affect public perception? Perhaps Ludo would want to take that one.
No, it is not. It is not correct. The information about suicide, about euthanasia, is also in the public domain in Belgium. It's freely available. There are some differences between the Netherlands and Belgium. One is that in the Netherlands you have to have permission beforehand, and we only have to send in a report after the euthanasia. That's a big difference. They also allow euthanasia in advanced dementia, on advanced care wills, but this practice it's only very rarely performed. But the information in both countries is freely available.
Ilora, you wanted to come back on something about Oregon?
Well, I just wanted to ask something, first of all, to Ludo, actually, in the light of what he's just said, because I understand that about 40% of cases are not reported officially. So why does Ludo think that clinicians are actually avoiding doing the reporting? And if I could pick up on something that Timothy said, he spoke about the numbers as 1 in 300. I make it almost double that number looking at the latest Oregon data. But also I wonder if he could explain why there is doctor shopping, where 90% of patients are stewarded by the campaign groups to willing prescribers because their own doctors are not willing to prescribe for them. That would suggest that their own doctors have reservations, but these are people who are determined and a willing prescriber. I think one person prescribed, I think it was 31 lethal prescriptions last year. And sometimes the patient is only known to the person. The reports, I think, said 0 weeks in the latest report. So the concept of this being a long-term relationship that you've laid out doesn't seem to be reflected in the official reports.
Ludo, would you like to take the first point first, and then we'll come to Tim?
There certainly is underreporting. How this is studied can be questioned. So it's not easy, of course, to detect cases of euthanasia which were not reported, because the reporting is our free choice, actually. A reason why doctors dare to not report is that there is no legal case ever succeeded against a doctor performing euthanasia. So the illegality or the feeling that we cannot be prosecuted is actually present. And I think that is the main reason that some people simply don't care of reporting what they are doing.
Can I take up on that? Is if people are, does that mean that people are happy to misuse the legislation or not to take all the safeguards if they think they're safe to be not prosecuted?
I don't think the legislation is misused, but part of the legislation is, of course, that you have to report it, and some people are certainly not doing that. And they say so in public, they say so in the press, and they are left alone by the judicial system.
Oh, okay. Can I come back on, if we're just talking about
like to take on?
Okay.
Yeah. Yes, Ilora for a moment.
Oh, I was just
Ilora first, and then we'll have Tim.
Thank you. I was just going to pick up on that, because we know that elder abuse is rife around the world and is actually going up. I gather that recent studies showed that 1 in 5 elderly people in Belgium have reported feeling that they are victims of abuse. And certainly in Colorado in the US, it's gone up by 103% in the last 6 years. So there is a real problem about elder abuse and coercion, and often that abuse is financial, plus or minus other types of abuse. But if you're not monitoring, then how do you know that these people weren't coerced, weren't pressurized? And if there is no legal case against anyone, that would suggest that the review committees are not being at all critical of what they're seeing, and they're acting as a rubber stamping body. We've had some scandals in the UK of doctors who did not behave well, of malintent. We've had doctors we've detected who have actually been mass murderers. And I don't believe that that is a UK only phenomenon, I'm afraid. And I just don't see how within your system, if there is no prior view and scrutiny is so light touch that it ticks off people, how would you ever detect if somebody was actually quite enjoying euthanizing people?
Just to react on parts of what you say, of course. First of all, the review committee is indeed not doing its work properly. I've been part of this reviewing committee, and I left the committee and I made my comments public, and this can be found. That's one thing. Actually, the main problem is that the law on euthanasia has not included punishments like how much you would get if you do not follow the law. It's simply not there. And so if you break the euthanasia law, you have to go to a court of assize and stand trial for drug murder or poisonous murder, and so that's not possible. And so they have tried this kind of legal case, but it was thrown out. And the main reason why why the judicial system doesn't know what to do with euthanasia is this, that there are no punishments written down in the law itself.
Tim, would you like to come back on some of the points we said earlier about Oregon?
Sure. I mean, first of all, any individual practitioner has very infrequent experience with this, right? Even if you care for a lot of really sick people. So a lot of practitioners may be very uncertain about this, and if a person wants this and their doctor is uncertain or uncomfortable, they may go to an advocacy group to find people who are more open to this, and they also know how the system works in that sense. Now, that you could say that's a bad thing or a good thing, but in point of fact, if you are really thinking about this, you want somebody who's got a lot of experience, who knows what they're doing and knows how to do it. There is a requirement for second opinions, so that you need to get a second opinion, and you need to have somebody who's committed to the process going through, particularly with assisted dying, because it can. A lot of people want to know there is this possibility for themselves, but they actually never use it. The knowing that you could do this allows some people to live much freer, and in point of fact, of the people who know the possibility, relatively few actually take it up finally. But they report feeling freer for the time that they have left, less trapped. So it's a complex question, and I think it does tend to fall to a shrinking number of clinicians who have experience in this zone, and that's got risks and that's got benefits depending on how you view it.
We've had one question. Thank you. We've had one question saying for Baroness Finlay and Dr. For Ludo, do you think your professional backgrounds, i.e. formal palliative care opposed to neurology, influences the way you look at the issue? Ludo, would you like to start?
I don't really understand the question. I will read it again.
Do you think
Yes.
being a neurologist,
Yes.
And seeing patients in that way has actually affected how you see?
It does. I think neurological patients are very vulnerable patients, and you have to be very careful. What is done to them? Is there indeed enough care? Are there people taking care of them? Are there enough facilities, and so on? And that's a discussion that I'm very sensitive to as a neurologist, far more than the very pro-euthanasia lobby in Belgium. That is true. On the other hand, I am of course trained in palliative care as well. I take up a lot of palliative care work in my hospital and in our hospice. So if the question is whether I'm properly trained as a palliative care physician to look at these aspects, I think I can answer that I am, yes.
For a neurologist, though, who was not trained in palliative care, it would be very wise to get a palliative care consult for anybody who is considering this, right? Because you'd want to make sure any dimensions of suffering that were present were being fully addressed. So a neurology and palliative care partnership managing such patients who are thinking about this would be ideal, I think, and in fact should be required.
Can I come in, David? Yes, thank you. I think it's a very interesting question, actually. In the UK, only about 30% of the funding for palliative care services comes from the NHS. And we have a more extensive coverage of palliative care than I think almost anywhere else in the world, but most of it's through the voluntary sector. Our training is also extremely rigorous in palliative care, and support amongst palliative care professionals is extremely low, and very few people see a need to have this in their armamentarium. In terms of the way that you answer the question when somebody says that they've had enough, they want to die, I think that is a frequent open conversation that we have with patients. And after thousands, literally thousands of such conversations in my professional life, when you ask patients, what is it that's making today so difficult? What are the things that you always wanted to do but think that you won't get to do? What are the things that are concerning you? You often find that people are frightened that at the night, at the weekends, at bank holidays, Christmas and so on, the services won't be there for them and they might have a crisis. And that fear is very real. So I do want to ask whether both in Belgium and in the US, you are confident that you have 100% coverage for 24/7 provision of care to patients and can provide them with that reassurance, because I certainly don't know of it, and I think that that's often a fear. But also we find things in those conversations that we can do something about, and it has been enormous numbers of people who say, I never believed I could enjoy life again. I never believed I could feel so well again. But if you go down the path of, okay, you want to pursue this, you actually reinforce the view that perhaps they'd be better off dead. And I think it does come down to what you see as your basic duty in palliative care, and that is to accept natural death, but it is not to actually end your patient's life early. It is to do everything you can to help them live well for as long as they possibly can. So I think that is a philosophical approach. In terms of neurology, well, there is financial stringency everywhere, and certainly Canada has produced some interesting data showing how they expect this to be a financial saving to services by having introduced these processes. So I wonder really also if you've costed out how much you feel that your actions are financially saving your healthcare system by not providing care to patients for longer.
And I come back on that as a little bit as someone who's been very interested in ALS for over 35 years. But when I look back at the patients I look back in the 1980s, we provided very different care then to what we do now. We were rarely doing non-invasive ventilation, helping breathing problems. We were rarely doing gastrostomy.
Yeah.
And actually, over this period of time, the care and what is provided for patients is actually improved a great deal. And, you know, are we at the stage that we just need to look at what we can do to help the patients? I can see we're still left with the autonomy issue, but the care provided could be improved. There's one comment just come through. I'm in the US in New Jersey, and one problem we've had about MAID is that people with neurological conditions such as ALS cannot actually pick up the medication and so are ineligible. So that actually their disability is stopping them having assisted suicide. Now that must be different because you were talking in Ludo in Belgium, they could have euthanasia, but Tim, is that an issue that people who are very disabled are actually not able to take up even what is supposed to be a right or option?
I would say, first of all, the assessment of these patients is incredibly complex. So it's the big challenge, I think we'd all agree, is to make sure that the person is really ready to make this decision. And also if we take the stopping life support decision, which I think would all agree is a permitted, people have to give their permission to be put on life support, and they can take that permission away. Again, it's a tough decision. If we take that as a model, it should be the same kind of model where you really get smart people, you get experienced people in palliative care and neurology and sometimes psychiatry, because you want to be sure they're sure, but then you have them work together and then decide if they are really at the right time to do this. And we are used to doing this, by the way, with people on life supports, right? At least in palliative care, we see almost everybody who's thinking about stopping a life support in our organization, because it's such a big decision. But because it's a big decision doesn't mean it should be prohibited or shouldn't be allowed to happen. We just have to exercise extreme care to make sure it's really what the person wants. A lot of people.
That was the challenge in neurology.
Pardon me?
And that's a real challenge in neurology, where cognition and communication may both be affected. And I think that's an extra challenge for neurological patients. I don't know how you feel, Ludo, on the issues, particularly with the neurology patients, from cognition assessing their ability to make these decisions.
No, I fully agree, of course, and especially the communication aspect is a very difficult one in multiple sclerosis patients. At the end of their life, they are often very hard to understand. Patients with stroke cannot speak anymore. So these are very real issues, and we have to be very, very careful about it. euthanasia is not very often performed in those very ill neurological patients. In the end, the numbers that we have in Belgium is at present is 2.5% of all deaths is through euthanasia, but these percentages are of course very different in different age groups and in different populations, and it's very high in cancer patients, but it's rather low in neurological patients. In ALS patients, on the other hand, is extremely high. I think over half of patients with ALS in Belgium die through euthanasia.
And perhaps one final question, Ilora. Someone said it sounds that any level of suffering could be addressed with good palliative care. Have you come up against truly refractory suffering?
Okay, there was also an earlier question to me, so can I answer both,
Yeah.
David? The first one was about,
yeah.
About public support. Actually, a poll just done recently has shown that only 43% of the population actually understand what's involved in supporting physician-assisted suicide and euthanasia. And of the remainder, over 43% thought it was stopping treatment and 10% thought it was hospice care. So I'm afraid if you just ask the public a simple question, you'll get a simple answer to it. But the public support numbers are really not accurate. They the public need to know what it is that they're supposedly supporting. When you look at suffering, I'm afraid there isn't a magic wand in medicine. Nothing in medicine is 100%. And part of being ill, part of life is suffering. In terms of looking after patients, I have gone back time and time again to try to address their suffering and what's happening. Yes, I have come across people with intractable suffering, refractory, and they were the parents of a child that was murdered. And there was no way that overwhelming pain of loss, that sense of guilt that they let their child get into the situation where their child was brutally murdered, nothing could take that away, absolutely nothing. And I'm afraid there always will be suffering in life. The question is, what is your medical duty? Is your medical duty to do everything you can to try to help people live well during whatever time is left? Or is your medical duty to say, actually, I'm happy to end your life now, and none of us know how much longer you might have lived for. None of us know what might have laid ahead. And there may well have been things that we could have done to make your life better. And the type of story like Tom Middleton in Oregon, who was coerced into physician-assisted suicide, that's been in the public domain. And the Roger Foley in Canada, who tried to get support for the social care that he needed but couldn't, but could get lethal drugs, makes me feel that changing the law in terms of medical duty is just too dangerous.
I would say I agree totally that we should be redoubling all of our efforts to address suffering. That is one of our fundamental obligations. I would also say that has to be balanced by a fundamental obligation to listen to the patient, what they're saying, because patients know what their experience is, they know what they need, and sometimes they do get to a point where they are done. And it may not, at least we have to listen to them and explore, try to figure out a way to keep going, but sometimes people are done. And again, if we use the people on life supports as an example, people have a right to stop a life support. We still are going to want to challenge that, but ultimately you have to listen to the patient if they really know what they need. And if it's not clear, you hang in there. You get smart people, you get people from the particular fields that are expert at what they're asking about. But ultimately, we have to also listen to the patient.
But I would say, Tim, too, in listening to the patient, you must have had the patients like I've had who say, yes, they're done. And they just let go of life and they die when they're done. And they often die when the family leave the room, or they wait for somebody to come from away and then they die. People do actually control the timing, the end of their death themselves anyway, in a lot of cases. But a lot of people talk about needing to be given lethal drugs, or give me something to end it, because they're frightened of what lies ahead. And often what they're frightened of is something that wouldn't even happen.
Thank you to all our speakers and all the people who put questions. I hope we've managed to cope with all the questions and comments you've put in. Thank you very much indeed. We have an answer of listening to patients, being there with patients, of helping them, and that we have to be aware that there are going to be differences across different societies, different areas, and we need to be aware of, most importantly, of the neurological patient difficulties that may present for any change in care because of cognition and communication and all those issues that we all know about in neurology. Thank you very much indeed to everyone who's been involved. We're happy to finish the session now. Thank you very much indeed to the speakers.